Next generation sequencing has identified a variety of mutations and genetic changes that occur in cholangiocarcinoma. One of the very common ones of these is the fibroblast growth factor receptor 2 aberrations and rearrangements, as well as mutations that tend to occur in about 10 to 16% of intrahepatic cholangiocarcinomas. Additional mutations include IDH1, IDH2 mutations. There can be ROS1 rearrangements that occur in about 8 to 9% of patients. IDH1 and IDH2 mutations occur in about 25% of cases. EGFR amplification has been reported in 16% of cases. HER2 amplification has been reported also in 11 to 20% of cases. And finally, a very small subset of patients have the BRAF V600E mutation, and that tends to occur in about 5% of patients. The targets that have been identified in some ways may be predictive of at least response if you have the appropriate therapeutic available. There is not a lot of information about the prognostic benefit of the various subtypes of cholangiocarcinoma, perhaps with the exception of the FGFR2 aberrations and rearrangements. Recently presented data at ASCO retrospectively looked at group of patients who had the FGFR2 rearrangement. That study identified that this aberration found in younger women. These patients have a tendency of having a normal CA19-9. They have a higher propensity for bone metastases. And interestingly enough, their response to first-line chemotherapy with cisplatin and gemcitabine is usually short, at about 6 months. However, taken as a whole, these patients tend to do a lot better, with the median survival of these patients being around 36 months. So as we have come to the realization that there are actionable mutations that occur in this disease, it's now more and more important to actually do next generation sequencing in all patients who have metastatic cholangiocarcinoma. And I actually am in favor of doing this in addition in patients who have locally advanced disease. It's important to identify these mutations early because of the opportunities to enroll these patients in clinical trials, or perhaps give them a targeted therapy for their specific aberration. Testing for next generation sequencing should be done at diagnosis in patients who have metastatic or locally advanced disease. And in select cases, it is reasonable to actually consider repeat testing at time of progression based on emerging data that shows that with identifying perhaps new mutations in the patients, we can selectively tailor their future therapies to allow them to have a better response.